Alright, so this is the first of the two lectures about the knee joint, and in this lecture we're going to be going over the osteology and all those important ligaments at the knee joint. So first the osteology. We're going to cut to the skeletal model for a second here. Alright, so here we have an anterior view of the right knee, and the knee consists of two joints, the tibiofemoral joint and the patellofemoral joint. First, the tibiofemoral is between the femur here, so it's called a bicondylar synovial joint, because it involves two sets of condyles. So the medial femoral condyle articulates with the medial condyle of the tibia. The lateral femoral condyle articulates with the lateral condyle of the tibia. Then you have the patellofemoral joint, which is shown right here between the patella, which is this bone right here, the largest sesamoid bone in the body, and the femur right here. And this is a saddle joint. So I just want to show you this here. This is a posterior view of the right knee. This region in here is called the popliteal fossa, and that's where the popliteal artery runs through. The sciatic nerve runs through this region. We'll talk more about that in a few slides here. So again, this is the lateral condyle of the femur articulating with the lateral condyle of the tibia, medial condyle of the femur articulating with the medial condyle of the tibia to form that synovial joint of the knee. And so for the patella here, we have two great views. This is an anterior view. This is a posterior view or inner surface view. And as you can see here, has these two grooves here. One, this is the facet for articulating with the lateral condyle of the femur. This one's for the medial condyle of the femur. And then, as you can see here, you have the quadriceps tendon. And the quadriceps tendon is where all four quadriceps muscles insert, and then they converge onto the patella here. And then the patella has the patellar ligament, which extends here and inserts onto the tibial tubercle on the proximal tibia. And that's just a bony ridge here called the tibial tubercle. And that's where the insertion point is of the patellar ligament. And so as you'll notice here, the patella is a sesamoid bone, which is a bone that's embedded within a tendon or ligament structure. And as you can see, it's the largest sesamoid bone in the body, actually. And it's considered embedded in the tendon of the quadriceps. Another point to make is that the knee joint is encased by a fibrous capsule. So you have all these ligaments, then you have actually a large connective tissue, strong capsule that surrounds the entire joint, and it attaches the femoral and tibial condyles to the patella, and you can see that right here. The menisci, so these are fibrocartilage pads, type 1 collagen. That could be an important fact for an exam question. They're anchored to the tibia, so this is a superior view of the tibia here. And as you can see here, here's the medial meniscus, here's the lateral meniscus. These are very frequently involved. You've probably heard of these if you're an avid sports fan. These are very commonly injured in athletes. And one thing to note is that they sit outside the synovial cavity, meaning the cavity between, the joint between the femur and the tibia itself, but they are within that joint capsule, that connective tissue sheath that surrounds the entire knee. They're C-shaped, as you can see, like this and like this. And they wrap around the tibial condyles, so this would be right here and here. And they attach to the intercondylar area of the tibia, and so that's where they wrap around like this, and then they attach into this intercondylar, between the condyles area. And they're just cushion pads. They're shock absorbers, and they act as cushion, and they receive the femoral condyles, and they reduce friction during movement. Again, it's all about, with cartilage and these structures at joints, it's all about easing movement as much as possible and reducing friction. So again, these help. And the knee is a very active joint, and it's also a joint that's responsible for a lot of weight bearing, so it needs all the help it can get. And then this is just a great posterior view. Here's the medial meniscus here, and then here's the lateral meniscus here. And there's some important anatomical relationships between the menisci and the medial collateral ligament and the lateral collateral ligament. And one thing I want to make note of right now is that there's a mistake in your book, and so please correct this before we move any forward, is that the medial meniscus is firmly attached to the medial collateral ligament, the MCL. I think it says in your book the lateral collateral ligament. Please correct that. And then the lateral meniscus is separated from the lateral collateral ligament, not the medial. That is what, like it says in your book. Lateral goes with lateral, medial goes with medial. Again, we apologize about that error, so please correct that. So the medial meniscus, it's firmly attached. So here's your medial meniscus here. Here's a posterior view here of your medial meniscus here. And as you can see, here's the MCL right here. And the MCL is very firmly attached to the medial meniscus. And so what that does is when you have an MCL injury, it can pull on the medial meniscus and expose it to injury and cause it to tear. So that's, you can have 2 injuries instead of 1, even though the ligament was more so affected than the meniscus. You can definitely have isolated medial meniscus injuries as well. The lateral meniscus, this doesn't really happen because the lateral meniscus is separated from the lateral collateral ligament by a tendon of the popliteus muscle. And you can see that here. Here's your lateral collateral ligament right here. Here's your lateral meniscus right here. And you can see it's sort of cut right here. This is the tendon of the popliteus, which is a muscle that sits down here in the posterior aspect of the knee, and we'll talk about in a little bit here. But this tendon extends up and then separates the lateral meniscus from the lateral collateral ligament. So there's no attachment between the LCL and the lateral meniscus. Some bursa. First, you have the suprapatellar bursa. This is extension of the synovial cavity, so the actual joint cavity of the knee, and it lies between the quadriceps femoris muscle and the femur, and you can see that right here. So here's the quadriceps femoris. So here would be your suprapatellar bursa right here. Prepatellar bursa lies between the superficial surface of the patella and the skin. So here's the patella, so that bursa would be right here, and then the skin would be coming down like this. So this is the most superficial. Then you have the infrapatellar bursa, which has 2 parts. There's one that lies between the patellar ligament and the tibia, and so that would be in this region right here. And then another one that lies superficial between the patellar ligament and the skin. So you have the other part right here. So there's a superficial part and then a deep part here on either side of the tendon. So prepatellar or infrapatellar bursitis, so that would be again in here, or potentially here or here. Presentation is going to be tender knee swelling. So, essentially these are bags of fluid that act as cushions. And so they can get, real inflamed, and they can cause the knee to swell. But however, it does not restrict the range of motion. So these patients will have full range of motion even though they have a very tender and swollen knee. The causes are either acute or chronic trauma. It's commonly seen in people with professions that require frequent kneeling. Diagnosis and treatment. It's a clinical diagnosis. There's not really, anything you do, just history, do physical exam. And then as far as treatment goes, you just do rest it, elevate it, give them some NSAIDs to calm down the inflammation, help their pain. And if it's really bad, you can do needle aspiration. So you can stick a needle in here and aspirate this. A popliteal cyst, or also known as a Baker's cyst, is excessive fluid production by an inflamed synovium. So that would be in the joint here. And it's an example that would be rheumatoid arthritis, osteoarthritis, and then cartilage tears. So tears to the cartilage of the knee joint itself. And that makes sense because these would cause a lot of inflammation. So they're going to lead to excessive fluid production in the synovium. And this is a posterior view here. The popliteal, as we mentioned, the popliteal fossa or popliteal region is on the posterior aspect of the knee right in here. And this leads to fluid accumulation in the popliteal bursa, which is right here in the popliteal space. And the cyst is in direct communication with the synovial cavity, and it arises in the posterior knee between the medial head of the gastrocnemius and the semimembranosus tendon. So it's going to right in here. And diagnosis, again, it's going to be clinical. You can do an ultrasound to confirm it, and you'll actually see the enlarged cyst. Treatment, you do rest, elevation. If severe, it can be aspirated with a needle. So now we'll talk about all the ligaments. So there's intracapsular ligaments and extracapsular ligaments. First, we'll talk about the intracapsular ligaments. These ligaments, they lie inside the knee joint capsule, so that connective tissue capsule around the entire knee, but they lie outside the synovial cavity of the joint, so they're not within the actual region where the 2 bones are articulating. And really, it's the cruciate ligaments, so the 2 ligaments that cross each other to connect to the femur. So you have your ACL or anterior cruciate ligament, and then your PCL, posterior cruciate ligament, and they cross like that. Then you have the transverse ligament, which goes between them, and you can see that right here. It connects both the menisci. And then here's a good posterior view as well. This would be anterior, superior, posterior view here. And you can see the PCL is here, and then the ACL is here. So the anterior cruciate ligament, or the ACL, as it's very commonly known, is very commonly injured in athletes. You hear a lot about this on sports news. It spans from the anterior intercondylar area. So this is your superior view again. Here's your ACL right here. Here's your intercondylar area between the tibial condyles. Here's the beginnings of the ligament right here as it expands from that anterior intercondylar surface here, because this would be your anterior, posterior here. And then it spans across. So here it is right here on an anterior view. And it spans across like this to go to the medial surface of the lateral femoral condyle here. So it goes from the anterior aspect between the two condyles on the tibia to the lateral condyle on the femur. And then you can also see that here. Here's a posterior view here, where the ACL, here they mark it here for you, it's traveling back this way to that lateral condyle. And so this is the medial surface, because it's, lateral out here, medial right here, attaches that intermedial surface of the lateral femoral condyle. So the ACL, it prevents anterior dislocation of the tibia onto the femur. So if we look at this sagittal view of the knee joint here, we have the posterior, anterior here. So it prevents the tibia from going out this way, which would be anterior translation on the femur. So, and in fact, the way you test this clinically is you do either an anterior drawer test, where you actually you hold the femur still, and then you with your other hand you pull the tibia out this way, and you pull it until it's taut. And if it's not too much mobility, that tells you the ACL is intact. But if you're able to pull it out, kind of like a drawer, pull it out more than expected, that can indicate the ACL is torn. Same thing, a Lockman test is just a different variant of the test, where same kind of concept, you're just pulling the tibia out, and so that can indicate a ACL injury. It also prevents knee hyperextension, so the knee coming out this way and extending beyond normal. Hyperextension of the knee, in fact, increases the risk of an ACL tear. So if someone's running and they incur some kind of injury where their knee becomes hyperextended, that can increase the risk of a ACL tear. Posterior cruciate ligament. So again, we have this superior view here. Here's your ACL right here. Here's your PCL right here, and you can see it coming off this way. This would be anterior, posterior. So it's really named for the area of the tibia it comes off of. The ACL comes off the anterior part, PCL comes off the posterior part of the tibia. It spans from that posterior intercondylar area. So again, here's that intercondylar area. And then it spans across. So here's the ACL here, here's the PCL coming up here onto the lateral surface of the medial femoral condyle. And you can see that right here. Here it is coming off that posterior aspect. This is again your posterior view. Here's your PCL right here. And it's spanning here into that lateral surface of the medial condyle, because this would be medial, and then this would be your lateral surface of the medial condyle here. So again, ACL like this, PCL like this, they cross. The PCL is less frequently injured than the ACL because it's shorter, straighter, and stronger. And you can actually see that right here. Here it is. It's nice and straight. It's a stronger ligament, and it's straighter. As you can see, the ACL kind of wraps around this way as a more curved course than the PCL. So again, here's that sagittal view of the knee right here. This would be posterior, anterior. PCL, it prevents posterior dislocation of the tibia on the femur. So opposite to the ACL, it prevents posterior, so dislocating out this way, and it helps prevent knee hyperflexion. So the knee, flexing more so than is necessary. And, the way you test this is a posterior drawer test, where opposite the anterior, you grab the femur and hold it steady with one hand, and then the other hand, you push the tibia back. And if it's nice and taut and you can't push it back too much, then it indicates that the PCL is intact. But if you're able to push it considerably backwards or posterior, then it can indicate that the PCL was torn. And another thing to note is that during knee flexion, the PCL is nice and taut, but then it's lax during knee extension. So the transverse ligament, as you can see right here, here's your superior view again, medial meniscus, lateral meniscus, here's your PCL here, ACL here. It connects the anterior portions of the lateral and medial meniscus, as you can see here and here, and it functions to prevent anterior dislocation of the menisci during knee extension. So the extracapsular ligaments, these are ligaments that are outside the knee joint capsule, and they're outside the synovial cavity. So even this entire capsule of the knee, these ligaments are on the outer portion of that. So first, the medial collateral ligament, or the MCL, also known as the tibial collateral ligament, because it attaches from the femur to the tibia. And as you can see right here, so here's your MCL here. This is an anterior view. There's a posterior view here. And then here's your MCL right here, tibial collateral ligament, or MCL, medial collateral ligament. And it attaches to the medial condyle of the femur proximally. And you can see that here. Here it is even labeled for you, medial condyle. And then it goes down to the medial surface of the proximal tibia distally, so down here. Firmly attaches to the medial meniscus, as you can see right here, and we talked about. So here's your medial meniscus, those nice pads between the femur and the tibia. And thus, injuries to the MCL can often cause damage to the medial meniscus. So it becomes taut during valgus stress. Now, valgus, I like to think of as lateral. So L and L. And what that means is, so if this is your medial side, this is your lateral side here. What that means is that the stress is actually pushing the tibia out laterally. Okay, so the force is coming from the medial aspect, but it's pushing it out laterally. The same thing would be as if you had a valgus knee, your tibia would actually be going at an angle where it would be coming out laterally like this. So this is a valgus stress, and as you can see, that would actually make this ligament taut. Here's your MCL right here. And so if you're pushing this way, you're testing the durability of this MCL ligament. And so you actually, that's how you test it on exam is you apply valgus stress to the knee, and if you feel that this is nice and taut and it gives you some resistance, that tells you the MCL is intact. But if you're able to put a lot of valgus stress on it and displace the knee significantly in the lateral direction, then that can indicate that the MCL is torn. It also becomes taut during extension of the knee as well. It prevents medial displacement of the tibia on the femur and valgus stress. So like we said, it prevents excessive valgus stress, which would be pushing the tibia out to the lateral aspect, an angle like that. If this would be your femur and this would be your tibia out like this. Now this is dramatic. This would be an example if the ligament was torn. And then it also prevents medial displacement of the tibia on the femur. So that would be, if this is your MCL here, you would prevent the tibia from moving out medially like this. Lateral collateral ligament, also known as the fibular collateral ligament, because it attaches from the lateral condyle of the femur proximally, and you can see that right here. Here's your ACL right, or LCL right here. And then it goes down to the lateral surface of the fibular head right here, distally. And so that's why it can also be called the fibular collateral ligament, because it attaches to the fibula. It becomes taut during varus stress. So varus stress would be, laterals out here, medials out here. Varus stress would be pushing in medially, so it would be causing this is the angle, the line representing the femur. It would be causing the tibia to go out this way at this angle. So it becomes taut during that, and that's how you test the integrity of the lateral collateral ligament is you provide varus stress. So you push this way, even though it's coming from the lateral side, you're pushing it in medially. You provide this stress to test the ligament, and same thing with the MCL. If the LCL is taut and you feel some resistance, that means it's intact. If you're able to push this much past normal, then that can indicate the LCL is injured. It also prevents lateral displacement of the tibia on the femur. So this would be lateral out here, medial out here. So it prevents the tibia from going out this way laterally and on varus stress. The patellar ligament or the patellar tendon, it's a strong fibrous band, as you can see right here, that extends from the quadriceps tendon. It's part of that whole structure that encases the patella, extending from the quadriceps tendon, and then it also has this main attachment on the patella itself. And then it extends down and inserts onto the tibial tubercle of the proximal tibia. And you can see that right here. Here's would be your tibial tubercle, which is just kind of a bony bump or ridge where the patellar tendon or ligament comes down and attaches on. One method of ACL repair actually involves using a portion of the patellar ligament, which take a little sliver of it like that, and then put it in and use it to replace or repair the ACL. So the popliteus tendon, which is a tendon coming from a muscle on this posterior aspect, which is actually considered one of the leg muscles, so it comes off this way right here, off the tibia, and then it has this tendon that would extend like this, and we'll cover this more in the leg lectures. It extends from the popliteus muscle, so you can see it right here. Here's tendon of popliteus. And it wraps around the lateral aspect of the lateral femoral condyle, as you can see right here. And then it travels between the LCL, which is right here, or fibular collateral ligament, as it's labeled in the diagram, and the lateral meniscus. And that concludes our lecture of the osteology and the ligaments of the knee joint. In the next lecture, we'll talk about the clinical pearls of the knee joint and then some of the neurovascular structures traveling in the region.